Hello again to our physical exam series. I'm Justin Clutcher, fourth year medical student, and today we're going to be doing the GI series of our physical exam. So we're going to go ahead and get right to it. Assume we've already done the door knock and the hand washing at this point. So hi there, my name's Justin. I'm a fourth year medical student. I'm going to be doing your abdominal exam today.
Awesome.
All right, I'm going to go ahead and just give you this drape just to make sure you're comfortable.
Oh, thank you.
All right, and before we get started, do you have any questions?
I don't think so.
Is there any particular portion of your abdomen that hurts?
Nope.
Let's have you lie back here, and then I want you to also kind of flex your knees.
Okay.
This will keep your abdomen nice and relaxed for us. All right. And I'm gonna just raise your gown up so I can see your belly. Are you comfortable?
Mm-hmm.
All right.
All good.
When we flex the knees, it's important to do this just because it's natural for a patient to kind of want to tense up their abdomen when they're lying supine. So by tensing the knees, it actually relieves some of that abdominal musculature so that when you start palpating, you don't have to fight through the muscle as much. Okay. To start things off, I'm going to just do a visual inspection of your abdomen. In particular, I'm looking for any changes to the skin, such as discoloration, lesions, scars. Particularly scars are important to check for because a lot of patients will have had previous surgeries to their abdomen, which we need to be cognizant of what organs are actually still within the abdomen whenever we're doing our exam. So if they have a very obvious midline incision or port placements, that could tell us maybe they've had a hysterectomy or maybe they've had a gallbladder removed. So those are always important things to ask your patient about if you notice those. We're also going to be looking for any obvious masses or swelling, such as ascites or protuberance of the abdomen. I'm not noticing anything unusual here. Okay, after we've done the inspection portion of the exam, we'll move to auscultation. The reason we want to go to auscultation first is any palpation we do on the abdomen could potentially stimulate the bowels, which would adjust the sounds we hear. So you'll take your stethoscope and you're just going to listen in all quadrants of the abdomen with the diaphragm of your stethoscope. And what you're listening for are kind of gurgly noises. You might hear some every couple of seconds, which is about normal. Or you might have to go a whole 10 to 15 seconds and not hear anything. And sometimes you might not hear anything at all. So what we'll start with is, normally you want to start in whichever quadrant they're not experiencing pain. She doesn't have any pain, so I'm just going to start on the right. And I'm just going to listen for a few seconds, listening for just any kind of trickling, gurgling noises. Once I hear it, I'm going to move to the next one. And then the next. And then the next. Ideally within all four quadrants. What these sounds can tell you is if you're hearing lots of sounds, that might mean the bowel's working extra hard. That could be a sign of diarrhea or gastroenteritis. Could also be a sign of a bowel obstruction because the gut is trying very, very hard to push against that obstruction, so it's actually overworking itself. You could also hear very few sounds, which could be also a sign of an ileus or a complete obstruction where basically the gut is no longer functioning. So those kind of the sounds we're listening for. Normally you're just going to hear a gurgle every couple of seconds, which is normal. After we've listened to bowel sounds, we also want to listen for any bruits of the abdomen. Normally you're not going to hear these, but in an older individual, maybe with atherosclerosis or as a long-time smoker, you might hear an aortic bruit, which could also be a sign of really bad atherosclerosis of the abdominal aorta. And you're typically going to hear that just to the left of the umbilicus. And so I will take the bell portion of my stethoscope and listen here. And what you're listening for is kind of a whooshing sound. I'm not hearing anything, which is quite normal. Another sound you want to listen for is a renal bruit, which would be just about 2 centimeters above the umbilicus to the left. And again, I'm not hearing any bruits, which would be normal. Okay, so after we've done our inspection and our auscultation, we'll then move on to the percussion and palpation portions of the exam. Again, it's very important to ask your patient if they're experiencing any pain, because ideally you want to get to that quadrant last. The least amount of pain we can provide before we have to get to it, the better. Again, she's not experiencing any pain at this time, so we'll just kind of start in the right upper quadrant for simplicity's sake. Okay, so step 1 is to be percussion. And we did this with the CV exam when we were percussing the lungs. It's the same concept. So you're just going to tap your finger in each quadrant. And ideally, in the right upper quadrant where the liver is, you should hear a more dull sound. But in the other areas where you have more hollow viscous type organs, such as the intestine or the stomach, you should hear a more tympanic or resonant sound because of the air. And one thing to do whenever you're trying to gauge the size of the liver could be to actually percuss from the lower right quadrant until you start hearing that change in sound. So for her liver is pretty much right at about the costal angle, which is quite normal for most people who don't have any kind of liver disease or hepatomegaly. Following percussion, we'll then move on to the palpation portion of the exam. And so the idea here is, again, trying to avoid giving too much pain when possible. You're going to do light palpation. It helps to put your hands like this, where one hand can kind of help give you a little bit of extra pressure. And so you'll start light, and you're just gonna ask your patient, do you feel any pain when I do this?
No.
Okay. And then you'll go a little bit deeper. Just put gentle pressure as the patient can tolerate it. And again, do you feel any pain when I do this?
No.
Okay. And ideally, they shouldn't feel any pain. That would be non-tender. You're also at this point feeling for masses. I'm not noticing any mass in the process. Now I'm going to move to the left quadrant, or left upper quadrant, excuse me. Any pain?
No.
And so in this quadrant, again, we're going to be feeling for the spleen, the stomach, the left lower quadrant. Any pain?
No.
This will be the sigmoid colon and the descending colon, as well as any small bowel loops that might be there. And then we'll move to the right lower quadrant. Any pain?
No.
This one's really important because at this point you're going to be getting the ascending colon as well as the appendix. So people who are having appendicitis, they'll be exquisitely tender here. And there's a couple of specific palpation techniques that we can kind of do as well. One of those is the Murphy sign, which helps to have the patient sitting up, just ever so slightly. And I'm gonna have you take a deep breath in. And what you're gonna do is you're gonna take your hand just underneath the costophrenic angle, and now breathe out. As they breathe out, you are putting gentle pressure with your hand in. Breathe in again, and out. If they don't experience pain, that's a normal sign. If they do experience pain, as that gallbladder runs up against your hand, it should be a sign of cholecystitis, where the irritation of the gallbladder is a sign that their gallbladder is inflamed. Normal, they shouldn't experience anything. Another maneuver we can do is McBurney's point, which is if you go to the ACES on the left, or sorry, the right, and then the umbilicus, about midway between there is McBurney's point. If you press down, if you elicit pain, that is a sensitive sign for appendicitis. She has no pain there. And then there's another technique called Brobsing sign, as well as rebound tenderness. This isn't really something you can explicitly test for, but whenever you are doing palpation, if say you're palpating on the right lower quadrant and they feel pain in the left lower quadrant, that would be a positive arousing sign, or vice versa. It's basically just pain is elicited the side opposite of the palpation. That can be a sign of peritonitis or appendicitis, or really any kind of inflammation of the peritoneum. And then the rebound tenderness is whenever you're pressing down, and then when you let go, they experience pain. Again, that is a sign of peritonitis. It shouldn't be present in people with a normal abdomen. Next, we're going to palpate for the liver and the spleen. To palpate for the liver, you'll start in the right lower quadrant and palpate up. The liver typically likes to live in the right upper quadrant just beneath the ribs. If you have liver disease or cirrhosis or hepatomegaly, you might get expansion of the liver downwards. So you would feel a change from the more soft abdomen to a more firm liver presence. So in a healthy individual, you can usually make your way pretty much up to the rib line before you really feel that change in firmness. For the spleen, normally you're not going to be able to palpate the spleen, but in individuals who have splenomegaly, it helps to start in the right lower quadrant and palpate and have the patient take a breath in. And you just kind of work your way up into the left upper quadrant. Another breath for me. One more breath. And then last one. And what you're doing is you're feeling, when they're breathing, you're trying to elicit that spleen to brush against your hands. And again, in a normal individual, you shouldn't feel anything. Finally, to finish off our palpation, we're going to test for the kidneys. And I'm going to do that only on this side, just for the sake of the video, but normally you would do this bilaterally. To palpate for the kidneys, you'll put one hand behind the patient and another hand in front of them, because remember, the kidneys are retroperitoneal organ. What you're doing is you're bringing it up towards your hand, and when you're palpating, if there's a mass or cancer of the kidney, it should be larger and you should be able to feel it. Normally, you won't feel anything. And again, you would do that on both sides. And then finally, we're going to test for costovertebral angle tenderness. This could be a sign of kidney stones. And so you kind of want to find about 2/3 of the way down the back, or maybe about halfway down the back. And with your hand, you'll put your hand here and then just kind of hit it. It does not take a lot of pressure to elicit pain. You're just going to ask your patient, did that hurt?
No.
And normally if they did have a positive sign, it would run down their leg into their groin because it's following those nerves into the groin along the ureter. Okay, so to finish up our GI exam, we're going to use this mannequin that is supposed to mimic ascites to do a couple of extra tests. As you can see on this mannequin, if I press, there's pretty notable fluctuance. I wouldn't recommend doing this with a normal patient because a lot of times these folks are in quite a bit of pain. But what's happening is there is fluid being displaced from the arteries and the organs into the peritoneum, and so you get a lot of fluid surrounding the viscous organs of the abdomen. So there's a couple of tests we can do. One of those is to do a fluid wave test, and normally you would have your patient place their hand along the midline of their abdomen. Because this patient does not have, I'm going to have Richard here help me. And so what you'll do is you'll place one hand on the other side, and then with just kind of a flicking motion, you should feel a wave hit this hand. And so that is a positive fluid wave test. And then finally, we will do shifting dullness. What this means is if we were to do our normal percussion, it should be pretty dull. Recall earlier that pretty much everywhere but the right upper quadrant is going to be rather tympanic sounding because of the air within the hollow viscous organs of the abdomen. but because there's all this fluid here, it sounds actually more kind of like a pneumonia of the lung because that water is displacing the energy of your percussion. So if we were to have the patient move over to their side in the decubitus position, all of that fluid is now down here. And when we re-percuss, it should sound more resonant because now those organs are no longer being covered with fluid. But if we were to go down here, it should still be dull. And that is shifting dullness.